Okay, we're back. This is Health and Welfare, and we are moving to look at S28. And we've had a lot of work going on with folks about fix the language based on testimony and concerns. So, Jen, why don't you walk us through what we have?
Okay. Good morning again, Jen Kirby from the Office of Legislative Counsel. The language. All right, so this is a strike all amendment to S28, which is an act relating to access to certain legally protected healthcare services. There are some new provisions in here. There are some, the Office of Professional Regulation asked to have some of the provisions around the professions they regulate consolidated in their Title III Secretary of State Office of Professional Regulation statute rather than in all of the different profession statutes. So that's some of why the bill is, if the draft is as long as it is because some of the sections are getting struck. Section 1 is a new section. This would amend the Public Records Act to exempt from public inspection and copying records held by the Office of Professional Regulation, Board of Medical Practice, or another public agency that issues one or more licenses, certificates, or registrations to engage in a state-regulated profession or occupation. If the records contain the telephone number, email address, physical address, or mailing address, or a combination of these, of an individual who has applied for or has been granted a license, certificate, or registration to practice a profession or occupation in this state, except that the public agency shall disclose any address that the individual has indicated as a public address in the record. Section 2 is where I have consolidated those provisions in the Office of Professional Regulation statute. So this is in 3 VSA section 129A, and they have an overall unprofessional conduct statute that applies to all of their regulated professions. And so this is adding some of the language that we had looked at in the individual profession statutes to that statute instead. So in the existing provision saying that it is unprofessional conduct to engage in advertising that has a tendency to deceive, this adds advertising, including advertising about healthcare services, and adds mislead along with deceive. But you'll see as we go through the bill that we've taken out the word confuse. That there have been some concern both on the committee and from others about that word. Also, adding to the provision in the existing law on delegating professional responsibilities, this adds including the delivery of healthcare services to a person whom the licensed professional knows or has reason to know is not qualified by, and then this adds any combination of training, experience, education, or licensing credentials to perform them. So it's not necessarily a difference in meaning, but just clarifying that it is kind of up to the person delegating their professional responsibilities to ensure that the person they are delegating to is qualified by some combination of training, experience, education, or licensing credentials. Permitting one's name or license to be used by a person, group, or corporation when not actually in charge of, and this is adding under existing laws, not actually in charge of or responsible for. This adds or actively overseeing the professional services provided. And then in the existing definition of healthcare services, just specifically adding in counseling, which is something that we've been adding into the statutes to try to, more appropriately cover the spectrum of healthcare services that might be provided that don't seem to fit in any of those other categories. Section 3, just renumbering this section of the bill, but otherwise not making any changes in this section that amends the consumer protection statutes. Except that's a thing. If there was the word misleading, we didn't have to do. Sorry?
This is all just striking, right?
So this is striking a lot of existing law, but not making any changes since the bill as introduced. So this piece that's broadening the scope of these sections from limited service pregnancy centers more broadly are the same as in the bill as introduced. Then we have a few new sections. These sections 4 and 5 are really sort of cleanup sections leading into section 6.
What page are we on?
We are on page 9.
Page 9, section 4.
So this is amending, that's a definition section. It's actually amending 2 definition sections. These are definitions that are used in a part of the statute books in Title 18. So the statute books, as we're used to talking about them, are broken into chapters and subchapters and sections, but actually larger than chapters are parts. And if you look in the physical green book itself, you'll see there are large parts that are groupings of chapters. We don't.
So this is sort of new.
Well, this
for me.
is
I mean,
very,
it's
it's very
never
old,
never
and
struck
we
me
don't, we
before.
can't see them online, which is
Yeah. Oh.
challenging. But in the books, they are organized into very large parts. And so these are definitions that apply to the part of the statute books, I think on vital records sort of generally is where we are. And so there's an existing definition of licensed healthcare professional for all of those statutes that last year, as I understand it, was amended to add naturopathic physicians just in chapter 107, but that addition was added in chapter 101, which is it's a challenging way to draft and understand the statute. So I'm trying to clean that up here by amending that definition in chapter 101 that says licensed healthcare professional, that currently says licensed healthcare professional as used in 18 VSA chapter 107 means what it means. Instead, we're saying for the purposes of everything but 107, it means a physician, physician assistant, or advanced practice registered nurse. As used in chapter 107 of this part only, it also includes a naturopathic physician. And that was the language that was added, I believe, in the government operations committees that allows a naturopathic physician to sign birth and death certificates.
Right. Okay.
But does not give them other authorities under this part. Yes. So then I've done the same thing in chapter 107. So section 5 is 18 VSA section 5200, which is the definitions section for chapter 107. And this says, as used in this chapter, licensed healthcare professional means, and now it has the list that includes naturopathic physician. Okay. All right. And this is all because in section 6 in the fetal death reports, there was a request to expand the existing language that just says physician to reflect that there may be other licensed healthcare professionals making for these reports. So that is how we backed into needing to make that.
So now when we
Technical
say
change.
that, we've got all the. we
So
have
now,
the
yes, so now
PA,
you know who's
the
doing.
NP, and the
Yes,
APR.
exactly. Married it up. I think it was sort of a last minute change last year. In another committee, another attorney, and you know how picky I am about drafting details. So, so that's the change that's being made to the language in section 6 for the most part, which is these fetal death report requirements and records, is to expand physicians to say licensed healthcare professional each place it occurs. And then in subsection D, broadening to say reports made pursuant to this section, because some of them are different types of reports, are for statistical purposes only and are not public records. And in addition to the requirement that they be kept confidential, this adds language that they shall not be disclosed or discoverable in any civil, criminal, administrative, or other proceeding, and would accelerate their destruction. So destroyed after 2 years, which is my understanding from the health department is what's required. Their record retention requirement under federal law, not 5 years. So really the change at the beginning of the sentence, I think, is really more for clarity, but the rest of it is expanding to say the confidentiality piece includes not being discoverable in legal proceedings and destruction after 2 years instead of 5. Section 5, apparently I didn't remember this, but I had is unprofessional conduct. So we have, this is the Board of Medical Practice Unprofessional Conduct Statutes, and I did talk to work with the Board of Medical Practice Office of Professional Regulation and others on these sections. So this is reflecting their concerns and consensus. So first we have a change to all advertising about healthcare services or medical business, not just of the services, but advertising about the services that is intended or has a tendency to, and you can see we've struck through confuse, so mislead or deceive the public. And then in subdivision 21, we've gotten rid of these examples of, or the specific language about providing active oversight over various things, and instead saying permitting one's name or license to be used if the person is not actually in charge of, responsible for, or actively overseeing. But it's not, there was any concern about a provider having to actively monitor the education of somebody that they're working for. The idea here is they need to be actively overseeing the treatment or services provided. And then delegation of professional responsibilities. This is this should all be consistent with the language we looked at in the OPR statute earlier in the bill, but to someone that the professional knows or has reason to know is not qualified by any combination of training, experience, education, or licensing credentials. Then no changes around the questionnaire piece. And then we get into, on page 16, the individual professions or in OPR regulated professions, where we had the language for each of those professions, just striking through those sections. So in the clean version, those sections of the bill would just come out of the bill. There'd be no changes to those statutes. There is still the change for the advanced practice register of nurses and their ability to do the use the adaptive questionnaire specifically for prescribing medication to terminate.
And that's on page 18.
That is on page 19 and 20.
Yeah.
So I've struck the part that's incorporated in Title III.
What is this down over here? 14. There was a concern by the Board of Medical Practice about the online.
Sorry.
Right, that's what I mentioned. I did not make
I
any,
know what it is.
You didn't make it.
I didn't make any changes about the adaptive questionnaire.
Okay, I do have a
Because
problem with that.
That's
The Board of
that's why I
Medical
wanted to
Practice
mention
says
that it's.
Well, we're gonna keep going.
Okay,
And we'll talk about what they said
So
at the
it's
end
still-
of their testimony.
It's still in here,
okay.
Not there.
because I did not make any, I was not directed to make any changes or request to make any changes. But you can certainly discuss whether you would like to. Section 7, Board of Medical Practice did ask to change, and I have to fix the section numbering. But did ask to just put in a change for consistency. So I've added the statute on anesthesiologist assistants that the Board of Medical Practice regulates. Just they wanted that same language about not qualified by any combination of, so we're on page 21 now, delegating professional responsibilities. If the professional knows or has reason to know the person is not qualified by any combination. So they just asked that all of their statutes be consistent there. For the physician assistant, on page 21, struck that confuse, so just say tendency to mislead or deceive. And added the word care, so we're always saying healthcare services. Page 22, striking through that, the changes in the licensing statute for osteopathic physicians, because they're just included in the OPR statutes. So that section would come out of the bill. Section 9 is the confidentiality of prescriber information on medications for legally protected healthcare activity. There were no changes in that section. Page 25, striking out the separate section on naturopathic physicians. Again, they're OPR regulated.
Section 9 is.
Section 9 is an OPR regulated profession, so they would fall under that Title III provision at the beginning of the bill.
Yeah.
Section 10 is adding, again, in a board of medical practice regulated profession, certified radiologist assistant, that language about someone who is not qualified by any combination of training experience, education or licensing credentials, and the act will take effect on passage. And is it.
Okay, so Jen, the high level here, what we're doing, can you just describe briefly? Because I know there are a lot of individual professions in here,
Right.
but if you could just give us the high level of what's going on with all of the professions, that would be.
Yeah, so
had.
So I think probably the easiest place to look at that is in the OPR
Okay,
statute. The OPRs are general and professional conduct statutes. So it is specifying that unprofessional conduct around advertising includes advertising about healthcare services and includes advertising that is intended or has a tendency to mislead, but does not include the word confuse anywhere. Delegating professional responsibilities to someone who the professional knows is not qualified by any combination of training, experience, education, or licensing credentials, and permitting your name to be used when not actually overseeing the professional services provided. Those are really the substantive changes. Right.
Found this on the floor and I think it's connected to the table somehow. I don't know what this is. Don't pull on it, Larry. No.
I would just leave it.
Yes,
since
that's for
everything-
IT.
that's from
Everything's
IT, they've
working.
been
Oh,
working,
they have, okay.
yeah,
I think that is really where
okay.
the main professional regulation changes are. But the idea being to keep the language consistent for all of the healthcare professions.
Got it. Okay. All right, questions on the language changes here that are proposed? I know you have a question, I'm going now. Are we good?
Yes.
Oh, okay, go ahead. What page?
Well, I several of them, but I guess page 3, it's one of the ones that's in several places.
Yeah,
I do think the language is definitely better than it was before when it comes to like the act of oversight using somebody's delegation for their license. I still think there might be potentially some of the same problems. But it, actually, yeah, actively overseeing, it's unprofessional conduct for not actively overseeing. So again, in my facility, we have somebody who has a license that delegates individual staff members, and that's it. They, they're not there when the medications are being dispensed, so they're using a license of somebody that's not even in the building. So, what constitutes actively overseeing? So,
For the regulatory board.
yeah, again, yes,
it is. I think the board wasn't on, I think we can ask the board. I think this is, what you're talking about is consistent with, the way PAs function and others function. So actively overseeing, we'll have to ask, maybe.
I mean, in this case, it's the Office of Professional Regulations. So if you want to talk to Lauren Hibbert.
We can phone a friend on that.
and then page 13, which is a very similar thing.
That's-
Any combination of training, on all those things. So I think, again, with that strikeout and then right before it with all that yellow text, I think it's a better language there, but I do also, again, have concerns about, not qualifying any combination of training experience, license credentials. Right now we have a staffing problem, in a lot of different areas out here. And I worry that might cause licensees to try not to learn much about these individuals that are staffing, because right now we have a lot of people in healthcare that are not, I would say, the most trained or experienced, because we're just kind of taking whatever we can get at this point. And not just in my field, but, so I worry that.
What page you what page you on?
13.
Okay, yeah, I'm there too. I'm not.
I'm not sure that's a fair.
Yeah,
Okay.
so I think what this has been gone over by trying to ask the group. I see Jill is here. Can you share with us who was in the group that helped, modify the language?
It was OPR, Board of Medical Practice, VMS.
If they're happy with it, they're not happy with it.
Yeah.
And-
So-
Yeah, it's not,
Yeah.
it's not my language. It is
No,
from-
it's not, yeah, it's consensus language from,
If they're happy with it.
yeah, that's fine.
Yeah.
So we don't need to phone, probably, any of it, unless you need further clarification. Okay, any other questions there? All right, good. So yesterday we heard from David Herlihy and the Board of Medical Practice on the asynchronous use of a questionnaire, asynchronous prescribing or of a drug. And if you look at his testimony, the concern isn't the asynchronous. The concern is that there be some initial attachment and discussion with the patient.
Yes.
So as we currently do it, my understanding, and I can get clarification from the Medical Society on this and others, that the asynchronous is done when you've had a remote appointment or a phone appointment as it currently happens.
That's what.
And so you're,
But he's interpreting this as you don't even need to talk to the person. And if the medical society is concerned, I don't think we should be taking out one thing because philosophically,
no, I hear your question. So this is from the Board of Medical Practice, is the question you're
yes.
asking. So what is the fix here? And I'm looking at Jill because you're here representing the Medical Society.
Yes, Jill Sudhoff Karen from the Medical Society, and we support this provision. And our position is if there's anything in that form that says, that indicates that there needs to be communication, there is communication. So you also had Clara Keegan come in on Friday, who delivers this care, and she talked about how she does that and that that the standard of care remains the same.
So the standard of care is that there is a link with the patient. Can we look at the language that's in the bill itself to understand what is, was it 14?
It's on 14.
Yeah, we don't want to leave it that. Page 14.
Okay, I can ask follow-up questions. All right. Entertain additional medical. All right. If that's the same standard we use for any other prescribing over the phone.
Yeah.
I can.
Oh, good. Yeah, no, I think that was an important question. We good? Any other questions on this one? It's been worked over quite a bit by the folks at the professional community and the regulatory community, which is helpful. Mike Fisher, did you want to make a comment?
Very quick,
Thanks.
Mike Fisher, healthcare advocate, just because I have not managed to say it out loud. The HCA supports this bill, appreciates all the work that's gone into it. And I just sent a quick note
Could you do that? I think that's helpful.
to you.
It's always helpful. to have that.
To be posted to that effect.
Thank you. Okay. All right. Any other questions or comments? I think what I'd like to do is, I think we're probably ready to offer a proposal of amendment. And, just look at our time frame here. Nerds. Okay. At 10 o'clock, we have two folks ready to testify on primary care. So here's my suggestion that we excuse me, that we listen to that testimony, and then I would entertain a motion on S28, and then we'll move on to S27 and S.
I will make a clean copy one more.
Yeah, okay, so we have two folks coming in. Toby Sadkin and John Aslin. They're here, or they're both, okay, terrific. Good morning.
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 Good morning. So we have two folks here, both of you here to testify, and I have the order of testimony is Dr. Sadkin and then John. Is it John?
Right.
Okay, in that order, Aslin. So we'll stay in that order. But before I ask you to testify, introduce yourself for testimony, we're going to introduce ourselves because you're new to our committee. So Senator Cummings, go right ahead.
Ann Cummings, represent Washington District.
Good morning, Senator Martine LaRocque. I live in Burlington and represent Chittenden Central.
Ginny Lyons, I represent Chittenden Southeast.
Sam Douglas, I represent Orleans County.
Senator Larry Hart, I represent Orange County.
Good. So welcome both of you. And so we'll start with Dr. Sadkin. Please introduce yourself for the record, and then we'll listen to your testimony.
Hi, Toby Sadkin. Thank you for the opportunity to speak with you today to share our grave concerns about the future of independent primary care in Vermont. As I said, I am Toby Sadkin. I'm a family physician, and I've been practicing in St. Albans for 32 years. I'm also the chair of Primary Care Health Partners since our group was formed 25 years ago. Primary Care Health Partners is a group of independent primary care practices. We do family medicine, pediatrics, and adult medicine. We're the largest physician-owned independent primary care group in Vermont. We take care of over 30,000 Vermonters. We have 10 office sites throughout Vermont, extending from the north to the south. We have offices in Enosburg Falls, St. Albans, Milton, Burlington, South Burlington, Bennington, and Brattleboro. We have 23 physician partner owners, and we employ approximately 200 people. To really understand who we are, how passionate we are about our work, and why we are so concerned, it is important, I think, to know something about our history. Our story dates way back to the 1980s when the physicians who would become the founding partners of Primary Care Health Partners were part of Community Health Plan, CHP, which was a regional HMO and for a short time merged with Kaiser Permanente. So we have been familiar with quality initiatives and capitated payments from pretty far back. And when Kaiser Permanente decided to leave the Northeast, we had a decision to make. We could stay together in some way, or we could all just disband and do our own things. A core group of us decided that what we wanted to do was to stay together. We didn't want to work for an insurance company anymore, and we didn't want to work for a hospital or an FQHC. What we wanted was to form an independent primary care partnership, and that is how Primary Care Health Partners was formed 25 years ago. And since that time, we have continued to be guided by our own mission, vision, values, and culture. That is the foundation of everything we do. The essence of our mission is really all about working collaboratively to take the best care of our patients. And our vision highlights our commitment to things like remaining adaptable, resilient, fiscally responsible, staying at the forefront of primary care using evidence-based approaches, embracing quality tools and new technologies, and advocating for independent primary care at local, state, and national levels. So at 25 years ago, with these guiding principles, we entered the world of fee-for-service medicine. And with that, we faced the challenges that were shared by all independent primary care practices. Things like trying to negotiate adequate primary care reimbursement with the commercial insurers, the difficulty in recruiting and retaining staff, both physicians and practitioner staff and support staff, because we couldn't really compete with the salaries and benefits that were offered by the hospital-based practices and the FQHCs. And our expenses continue to increase far faster than any adjustments in reimbursement. Costs for things like health insurance, premiums for our staff, as well as things like utilities, supplies, rent, insurance, and our offices struggled to make ends meet. There was a time when some of our physician partners took drastic cuts in their own compensation, paying themselves only enough to cover minimal living expenses and health insurance, just in order to keep the practice open. And just as we were facing the difficult reality that some of our practices might need to be closed, the ACOs were created and offered alternative payment models, including value-based care. So in 2014, we made the decision to join OneCare Vermont. And this was a return to partial capitation with a focus on value-based quality measures. And this was something that was familiar to us from our old HMO days with CHP. And it was the first real investment in primary care that we had seen, especially the Comprehensive Payment Reform Program for independent primary care practices. This provided us with things like monthly capitated payments, extra funding for a mental health initiative that was focused on better access to mental health services for our patients, a population health model with an opportunity for incentive payments based upon achieving quality targets for things like preventive visits, blood pressure management, follow-up after emergency room visits, and depression screening. And this investment by OneCare into independent primary care really helped to stabilize our practices. This allowed us to expand our services and support to our patients through things like care coordination, community health workers, and increased mental health services. In addition, by participating in an ACO, this satisfied our CMS MIPS reporting requirement, which alleviated significant administrative reporting burden for us. But now we find our future really uncertain and tenuous. With OneCare Vermont ending at the end of this year and the decision of the state to delay the start of the CMS Ahead model until 2027, this leaves us with a looming disaster for 2026. We are facing losses of the ACO-funded programs, including the Comprehensive Payment Reform, the Population Health Model Value-Based Care Funds, the Mental Health Incentive Funds. And in addition, without participation in an ACO, we will lose the exemption from the MIPS reporting requirements, and we will have to resume this expensive and time-consuming administrative burden. We will also face the loss of some Blueprint-funded programs, funds for things like community health teams, mental health expansion, and the Dulce program for some of our pediatric practices. Taken together across all of our primary care health partners' offices, these programs fund nearly $5 million. Without these funds, we face serious consequences. At the very least, there will be loss of some crucial services for our patients, such as care coordination and mental health access. But our biggest concern is that without mitigation of these losses, some of our offices will not survive. Primary care offices will close, leaving patients without access to primary care and leaving our employees without jobs or health insurance. So ongoing investment in primary care, and especially independent primary care, is so essential. We are looking to you to help mitigate this looming crisis by finding ways to support independent primary care. The time is short. 2026 is not that far away. This really is serious and imminent. The work we are so passionate about and the healthcare of Vermonters really is at stake. thank you again for the opportunity to speak with you. I sincerely hope you can help. I'll turn it over to John for some additional comments. Thanks.
Thank you. It's a bit scary. You felt to really emphasize what we've been hearing about and the need for investment and support of our primary care community. So thank you. Go ahead, John, go right ahead.
Good morning. My name is John Aislinn. I'm the Chief Operating and Financial Officer for Primary Care Health Partners. Thank you for the opportunity to speak today. Some of what I have to address or speak to today reiterates things that Dr. Satkin had just mentioned. I see the world from the financial side, and I could definitely see the sacrifices that were being made leading up to OneCare's implementation of the Comprehensive Payment Reform Program, which we often just say CPR, which was really appropriately named for what the program was doing for independent primary care. Basically leading up to 2018, which is when CPR was implemented, I could see the financial condition of our practices just deteriorating year by year. And to the extent that an office accepted Medicare or Medicaid patients, the situation was even worse. And there were some great programs like Blueprint, and that was obviously additional funding for the offices, but that wasn't enough to solve this situation that was getting worse by the year. And I could see by 2017 that there were some offices that probably weren't going to last another year. And, I go back to Dr. Satkin's testimony about physicians taking pay cuts. In the independent primary care world, there's nobody else picking up the bill but the physician owners. And they just take it out of their own compensation. There's no guaranteed compensation in the independent world. And obviously, when you have a physician who has to cut his compensation down to just cover his benefits, that's not sustainable. And it certainly isn't possible to try to recruit practitioners into that kind of an environment. On top of all of this, you have the situation where it's just the physicians themselves are just burning out. They're working harder and harder on a fee-for-service basis to see patients, along with the administrative burdens from the carriers. It was a very difficult situation that we were in as we were coming to the end of 2017. And I thank OneCare for recognizing the dire financial situation that was out there and that they'd be so creative to come up with this comprehensive payment reform program. That program, it's important to know, was a combination of investments from the hospitals and the state. And that was basically put through to supporting independent practices, and they were meaningful investments for primary care. When you look at the CPR program combined with the population health payments, along with the state's Blueprint programs, including expanded CHT and Dulce, and most recently, we have all the investments in the mental health initiatives, it stabilized our practices, but also brought new life, new energy in terms of being able to provide that primary care to the patients. In a way, you might say that the CPR program effectively removed the penalty for seeing Medicare and Medicaid patients. There was this new investment coming in. But Dr. Satkin and I have advocated, we've written editorials and we've gone to the Mount Care Board. We've just advocated so much for how great the CPR program has been for our practices. And now we're in a tailspin with the decision for OneCare to close at the end of 2025. And we're not really sure to what extent the AHEAD program was going to be able to provide support. We really, in terms of all our pediatrics, we weren't really sure what would happen from Medicaid. There are a lot of open questions. And now that's basically obviously pushed out to 27, that 26 is looking really scary in terms of how we're going to deal with all the changes that are happening with the funding that we were seeing through the end of this year. We are just basically seeing a return to the pre-CPR days. And the same practices that I said, boy, they were saved when we came into the CPR program, they're at the top of my list to wonder whether or not they're going to be able to survive again. The enhancements from the capitation program that's lost, the continuation of the population health payments, we are uncertain, we're not sure. The combination of those two alone are $3 million to our group over our 10 practices. And if that wasn't bad enough, now we're hearing some questions regarding Blueprint. whether or not there'll be funding for for continuing the expanded community health teams or for Dulce. And any further reductions in any other area just adds to a big hole that we're trying to wrestle with. So as we now look at look into the future, desperately trying to save the financial situation of our practice and looking for any opportunities, we're also trying to understand to what extent really the hospitals were supporting the CPR program. Because even if the state were to level fund their commitment to what was provided to the program through this year, it's still not going to make up for the loss. There's another element in there that supported the independent practices. But unfortunately, with the ACO going away, the hospitals lose a vehicle to support primary care, right? There are guardrails in place that prevent a hospital from simply providing a subsidy or providing that additional payment directly to the independent practices. And we realize that when you factor out CPR and the population health payments, and and also the blueprint payments for some of our offices, that's up to 1/3 of their income. And I go back to what Dr. Sadkin said. If an office loses that amount of funding, I mean, well, maybe we get by with cutting some programs and maybe get by with cutting some staff, which would not be good, or the worst situation, closing a practice altogether. And so I included in what was submitted for testimony a document that the Medical Society has put together about funding requests for 26. And I was going to touch upon some of the items that are in there relative to my conversation today, where they had submitted a request for $5.5 million for population and CPR funding to cover the gap between the ACO ending and ahead. So we're talking the Medicare population. There's also a request for $10.8 million for the lost Medicare payments in support of the Blueprint program. And there's also support for the continuation of Blueprint expansion. There's a request for $3.1 million for Blueprint mental health and the substance use disorder, as well as $635,000 for the Dulce programs, trying to continue those programs. And also, they were following back to fee-for-service, a request to increase the Medicaid professional fee schedule by an inflationary adjustment of 3.5%. In addition to what the Medical Society said, I also would hope that the Medical Society, I would hope that Vermont Medicaid would continue its investments in primary care, even absent the ACO, that we find a way to continue to direct that money to primary care. But it's also important to note that, I go back to my point, right now, all of this, if it can happen, it's going to be helpful. Any amount of funding is going to help us try to work through the impact of this. But the big question for us still to wrestle with is, what about the hospital funding? And are we really covering that, or is that really still a gaping hole that we need to resolve? Unfortunately, we reach out to OneCare, and they're going to help us try to understand the magnitude as we're working through trying to find that landing point for next year. So I thank you for your time today, and I appreciate any support that you can provide, or any of your support and measures that stabilize independent primary care. Thank you.
Thank you very much. And you've given us a lot here, some of which is significant policy, which we're working on. And the other part will deal with our recommendations for the 2026 budget. And so we'll be looking at this in context of our recommendations to the Appropriations Committee. And we hear you. We know what's happening. We know ahead is leaving, and we have a gap year should we go ahead the next step. And the gap year, it could be very significant or provide significant losses, particularly to primary care. So we appreciate your information. We are not the Appropriations Committee. We are the Policy Committee. We have consistently been in support of many of the programs that you're talking about here, SASH, Dulce, and obviously Blueprint, big deal. So we appreciate having the data that you supplied to us. So thank you very much. Questions, committee? Huh?
not for them, questions for us.
I know questions for us, right? Well, you know what is good to hear in many, for me in many ways is the value that the ACO has provided and the value-based care that or payments that you have received and that has supported primary care. So that's important. The current concerns that we all hear about ACO relate more to the lack of a larger patient pool. So it's been difficult to do all the work, but we appreciate your comments on that very much.
So what's happening to the money the ACO had?
We'll talk about that. Okay, thank you. I think we're going to just take a quick break and we'll come back when Jen is back to talk about